In 2018, President Uhuru Kenyatta launched the Universal Health Coverage that seeks to ensure that Kenyans can afford quality healthcare at an affordable cost. Well, almost 5 years down the line, we track the progress of UHC. This week on Inside Government, we are joined by the chairperson of National Hospital Insurance Fund, Lewis Nguyai, as we discuss this topic. Thank you very much indeed for finding time to be with us.
Thank you very much, O'Brien, and welcome to NHIF.
Asante sana.
Yes.
Help us understand what is the role of NHIF?
First, I think it's very important to understand what universal health coverage is. And I think even though it's the core mandate of the one part of the mandate of the Agenda 4, in 2010 we passed the Constitution. And one of the rights that Kenyans granted themselves is the right to health. So the whole idea is to see how Kenyans can be able to access health care at an affordable cost universally. So universal health coverage is ensuring that each and every Kenyan can access health care at an affordable cost. For those who can afford, it should be mandatory for them to pay. And that's one of the initiatives that have been there even before, when some statutory acts were put in place and NHIF was created 55 years ago. So what we are actually doing is expanding that health coverage. And in 2018, which is 3 years ago, when the president in his second term decided that he wanted to have certain pillars of success, he chose universal health coverage as one of them. And there was no other organization better than NHIF. One, because of its historical experience. Two, because it had already started covering a majority of Kenyans, to be the one, to be the vehicle to ensure universal health coverage. Nonetheless, at that time, it was not structured sufficiently, and so the pilots were put in place. Tests were looked at to see where we would go right and wrong. A committee of experts was put together of different knowledge levels and different cadres of people in different areas in the area of healthcare and insurance. And they came up with 55 recommendations. Of those 55 recommendations, we have continually tried to implement them so that we can transform ourselves to have the capacity to deliver universal health coverage. So right now we've covered 34 of those. And I think the bigger issue is now how we can deal with the 19. And within that time, we believe that we should also now have increased the percentage that is meant to be covered to achieve universal health coverage. Real universal health coverage is at 100%. Our target is to first hit 80%. And I think we are way on track in that direction. Yes.
And when you talk about 80%, you're talking by what time frame and where are you now?
At present, we have surpassed the 50% mark. I think we have moved, we've increased ourselves within the last 1.5 years from I think 43% to 50-something%. But more importantly is that we have now started embracing the informal sector, which the majority of them are voluntary contributions. As late as yesterday, we had a partnership launch with the Border Association just to make sure that we are continuing to spread the wings. But one of the challenges that we have, and I think that's one thing that we will have to look into, is sustainability. Because if you're in the informal sector, luckily O'Brien, you're not, you need some way to remind yourself to pay the 500 shillings that you're meant to pay every month. I think in that area, I think in just the way we can enhance our own revenue collection, we can be able to now continue to expand and widen the net.
And when you look at, NHIF, I mean, as the underwriter with the highest number of people in this country, that comes with a challenge, because you have also to cater for the informal sector, whereby contribution are not always updated. How would you plan to deal with this?
I must say that most people don't realize, but NHIF, and this has been my pleasant surprise for the few months that I've been here, is the financing backbone of health care in Kenya. There is not one institution that is accredited to NHIF that can survive now without NHIF. So at present, I would say that NHIF is the ideal vehicle to be able to continue to expand that financing of healthcare. But when it comes to the internal issues, particularly in the issue of revenue collection and risk management, it's a learning curve. We started with a pricing of 500 shillings per family. And with that 500 shillings, you have a pretty comprehensive package that can take care of your healthcare for yourself and your family. And it's only 500 shillings per month, 17 shillings per day. And it doesn't matter the number of family members you have. If you go to a government-based institution, faith-based institutions, you are comprehensively covered. But when you go to private institutions, which some of the pricing is sometimes extremely commercial, then we do cater for at least the rebates on the beds. But if it comes to the other major packages, for example, if you have dialysis, we still pay the 18,000. Now the question is, are we meant to make a surplus, or do we do risk assessment and continue to provide social insurance? Now, from my perspective, and I believe that's the board's perspective, and that's also the perspective of the government, we are social insurance. So we'll always have to play tug and pull, making sure we give as many benefits as we can to our members and collecting what we can. At that, imagine it's just 500 shillings per family, and the array of benefits sometimes ranges. I've met people who have utilized our services per person up to 3-4 million shillings, depending on the condition they have.
The beauty about you is that you've had a stint in the insurance industry in the past. Mm-hmm. When you look at the model of National Hospital Insurance Fund vis-a-vis the contribution and the mandate given by the state, mm-hmm. Do you think that's a sustainable model?
One, I must say that there are quite a number of factors that you need to look into when you look at the behavior patterns of the claims. And one of the biggest problems we have, and that's one of the key issues that we'll need to deal with, is the fact that a good percentage, probably 20 to 30%, and you also saw it being shown in the press recently, the chairman of Jubilee Insurance, who said 30% of their claims are fraudulent. Mm-hmm. I'd say most likely, almost with certainty, 30% of our claims are fraudulent. So one thing is we need to check, are the leakages only on a real basis where we can then push the costs higher, or can we reduce the leakages and keep the cost of having universal health coverage at an absolute minimum for both those who can afford and the others who can afford, who will and have already been sponsored by the government?
In the past, there has been attempts to raise the minimum figure from from 500 bob to about 1,000. Mm-hmm. This has been met by serious protests, especially from the informal sector, mm-hmm. as well as people who are also in formal employment, but they are not earning much. Yeah. Is this an avenue that you're likely to pursue going forward?
Okay. First and foremost, I want to distinguish between the formal and the informal sector. Within the formal sector, there's a stratum that is dependent on the amount of remuneration that you're getting. So if you are on the lowest remuneration, you're even paid for less than 500. But if you obviously have a high income earner, it can go up to a maximum of 1,700. And that 1,700 takes care, as far as we are concerned, of the fund, the whole formal sector, of the fund in a much more sustainable way than the informal sector. And that's why I'm saying when it comes to the informal sector, we have to find a way of making sure that the contributions are consistent. Now, one thing that we have done is we have now put in the amendments that are being proposed in Parliament is that anybody who is above 18 years of age, it is mandatory for them to start contributing to NHIF. So once you hit 18, if you have an income, it is mandatory. And as you know, for statutory deductions, it is criminal not to contribute. So we believe with that, we will be able to ensure that the people in the informal sector can voluntarily start contributing more, even though it is now a mandatory, but also look for ways of enforcing it from a statutory function. When it comes to the formal sector, we also now need to understand that we want the contributions from both the employer and the employee, again, to enhance the value of the fund so that it can give that universal health coverage. And I would say that even though there are a lot of actuarial simulations and models, the real proof of the pudding is in the eating. What we would not want is to overburden any of the sectors. We would want to first get an experience from what we have now provided and hopefully will be passed by Parliament as quickly as possible to see how we can expand that fund, enhance revenue collections, close in the leakages, then come to, at one point in time from experience, to know, say this is the correct absolute pricing for both the formal and informal sector.
You're talking about, increasing coverage among the informal sector.
Yes.
And when you look at a country like Kenya, whereby 7% of jobs in Kenya are informal,
yes.
And this is where you have the critical mass. This is where you have the big numbers.
Yes.
So, what measures would you put in place, or do you plan to put in place, to ensure that people feel left out when they are not contributing to NHIF?
I think there's a lot of publicity that needs to be put in place. One of the things I would urge our media to do is to look at the good things that the fund has, and we also have to do that from internally, from a strategic initiative. It has to be education. Real education to people within the different sectors. We have had a very good buy-in from the border industry. We are getting a very good buy-in, and very soon you'll see from the matatu industry. If in those two sectors we were able to convince them, then they can also be able to convince their own customers, who again are the majority of Kenyans who either travel by boda or matatus. And we can also now look for the other parts of the informal sector, whether it will be the mama mbogas and the rest. But I think we have to start telling our good stories. And we have a lot of good stories.
We are talking about universal health coverage, and in a country whereby the health sector is a devolved unit, I mean, is a devolved function of county government. And when you look at budgetary spendings by county government, you're talking about 20 to 23% of their budget going to the health sector.
Yes.
And the investment that is needed is much more bigger than this. So how do we then stimulate expenditure or spending in the in public health sector?
There are many facets, I would say, of universal health care, which is universal. Now the umbrella, which is universal health coverage, comes under that. We address the universal health coverage from a financing perspective. When it comes to that financing perspective, we have put in models and rules and regulations and laws that are being amended. But from a broader perspective, we are also amending the Health Act, the Health Delivery Act, and not only from a national level, but even within the county levels. One of the challenges is obviously the amount of budget that goes into providing infrastructure for healthcare. But that's a segment that has its own experts, and the details of how they're going to do the delivery is really their business. My business is to make sure that any person who takes that service to their facility, gets paid for the services that they are demanding. Now, my parents' ministry also has the responsibility of making sure that the services and facilities are there. But for those services and facilities, there is a ministry headquarter, and I wouldn't want to misquote any of their strategies. So I will focus only on the financing of the members of NHIF.
Policy decisions that are made elsewhere, of course, are going to affect you, as an institution.
They do, and particularly on the devolved sense, we do have a lot of synergies and strategies that we carry out with governance and the devolved units. I don't think there's a week that passes, and I'm sure you can see in the media. Last week it was Kitui, the week before it was Nyandarua, where we don't have initiatives that we co-join with the county governments. Either it's membership recruitment, or it is delivery of one form of partnership in terms of infrastructure. We do have those initiatives.
You're looking into a country where almost 45% of the population, they earn less than 150 shillings, on a daily basis. That's about $1.50 at any given day. And you would expect them to be paying 500 bob to the National Hospital Insurance Fund. Do you think you're asking for too much?
150 shillings per day translates, of which less about 17 shillings is meant to go into the pocket of National Hospital Insurance, is obviously a bit of a challenge. But the ones who are identified as not being able to perform or to afford, the government has agreed to step into those shoes. And that's where now the gap between the ones who can afford and the ones who cannot afford. And this year alone, after the pilot that was successful, the government then started the initiative of identifying 1 million of those who cannot afford. And I'm proud to say that a few weeks ago, we hit past the 1 million mark. And we have been assured, and we're just waiting for the funds to hit our account, of 6 billion to cover for a whole year for that 1 million.
I mean, it's proper to say that, a million people who cannot afford to pay for the scheme. I mean, when the government is taking care of this, one can argue it's a good starting point.
It's 1 million families.
1 million families.
Yeah, so it's about 4 million people.
One would argue that it's a good starting point. But when you look at it, from a broader perspective, whereby you're talking about more than 10 million people, you're still not even halfway. How long do you think this can take you before you manage to get everybody in the basket?
It's 1 million families, 3.9 million people. We are 39% if it is 10 million people. So we are almost at 40%, and we are having our learning curve as we move on. Once we hit the other 60%, the budget was 6 billion last year. Obviously, the 42 billion is not only to universal health coverage from a financing perspective, but also from an infrastructural perspective. All we need is probably times 3 of that 6 billion to hit 18 billion, and we'll be home dry. So that is one of the key pillars of Agenda 4 that can be achieved, I'd say, up to 90 to 100% within the tenure of our sitting president.
And when you look at our expenditure in the health sector, we oscillate between 7 and 8% of our national budget. Kenya is a party to the Abuja Declaration that commits member states to commit about 15% of their national budget to the healthcare sector. And when you also look at the Kenya Health Sector Strategic Plan, the whole plan was to ensure that we get to 12% of our national budget. We are yet to get there.
Yes.
This is likely definitely to drag your efforts to bring everybody under the UHC coverage, right?
I think even the universal World Health requirements are at 15%, so they're in line with the Abuja Declaration. I will be happy to see the day that the 15% is achieved as a national country. Obviously, when there are deficits, those deficits will affect ourselves. But I must say that the deficits more hit the delivery of other health services like primary care. They hit more the delivery of equipment, the building of infrastructure and hospitals. But from our perspective, I think we look at it from what our mandate is, and our mandate is financing of healthcare through insurance. And in that sense, the government's mandate to us is to meet the cost for the indigents or the ones who we cannot afford. And in that sense, we are at 40%. We expect that the 60% will come, and will come within this coming year.
Globally, and this is not a challenge that is facing Kenya. I mean, when you look at the global picture, you have almost 50% of the world population. They do not get the health services that they need because of cost, because of lack of proper infrastructure. Here in Kenya, you have about 7 million people every year not accessing or not going to seek medical services because they cannot afford. As a national health hospital insurance fund, how best do you believe we can deal with this challenge?
Okay, I think the policies and the framework is in place. The legislation is being put in place. With that policies and framework in place, the support systems and regulations should be then implemented. But some of the challenges are now of a more practical nature. I'm sure it is easy in Nairobi to get access to people who you can obviously see cannot afford. It might not be the same if you go to Wajir, or if you go to Turkana, or if you go to somewhere in the middle of Taita. So it has to be a concerted effort, and that concerted effort has to include other arms of government, and all arms of government are key. We have to cover 100% of the population. Some initiatives that have been done from this end is some sectors are covered whether you have been registered or not. I'll give you an example, Linda Mama, which is an initiative that ensures that any person in Kenya, any lady in Kenya, does not suffer financially in delivery. You don't even need your ID for you to deliver. Immediately, you take yourself to the institutions that are accredited to provide Linda Mama. One best example in Nairobi is Pumwani. We will pay for that delivery, and we will pay for that delivery whether you're a member of NHIF or not. And we have the funds because the government provides 4 billion for it. If you look at Eduafia, any school-going child who is in secondary, who is in a public institution, is covered comprehensively for health insurance. So there are different strategies to make sure we access.
In the past, NHIF has been rocked by mismanagement of funds, or allegations of mismanagement of funds. And this has somehow eroded the confidence of the public, in the institution. You are barely 3 months into this institution.
Yes.
How do you plan to deal with this with your board?
There are two ways of looking at it. There's the internal mismanagement, which is now a managerial function where and it can be from a small level to an up level. About that, we have to have absolute zero tolerance to that. And I think we passed that message the first day I got into office. We said, if there are malpractices internally, you are interdicted, investigations are done. But we also have a compliance department that really has to be expanded and enhanced. But then there's also the system that really needs to be watertight. But there's now also the external. Some of it now is by our service providers. One of the most punitive we have done is if you are cited with fraud, there is an immediate fine on your account of 10 million shillings that is now has been embedded in the Act. But I'll say this, corruption, theft, mismanagement is a dragon that has a number of heads, and we will try and slay as many heads as we can, and if possible, slay down the dragon.
Very well. Anything else?
I'd want to urge the Kenyan, every single Kenyan, to look at the direction NHIF is going, particularly as far as delivering universal health coverage, and to be very curious and keen to know how it will benefit they themselves, and join and ask questions. One of the things that our population is not very aware about is that the ones who have technology, we have My NHIF app. It is right on your phone. You can download the app, and if you're not a member, you can become a member from the comfort of your seat. The final thing is that in terms of delivery of managing that fraud losses, we have now completely computerized what we call the e-claim system. In the 11th of this month, July, we are completely locking off all manual claims, which I'm sure will help save the fund at least 10 to 20% of the leakages that it has. And secondly, any Kenyan does not need a card. All you need is your fingers, where the service is being delivered, or where there is an NHIF office. Register yourself and start enjoying very, very well designed comprehensive insurance coverage, and protect yourself and your family.
Very well.
Thank you.
Thank you for your time.
Thank you.
Lewis Nguyai is the chairperson of the National Hospital Insurance Fund, joining us this week on Inside Government as we explore the topic of universal health coverage. And of course, you have heard it from him. My name is O'Brien Kimani. Thank you for finding time to be with us. We do this again next Friday, same time right here on KBC Channel 1. Bye for now.
Thank you.